The world's best physios don't just treat, they coach. Welcome to the Physio Coach Podcast. This episode is sponsored by Jane App. Jane is a practice management platform that helps clinicians like you and I spend less time on admin and more time caring for people. From online booking and scheduling to notes, reminders and billing, Jane is designed to reduce the day-to-day load on busy clinicians like us. After a few years of running Better Physio Group, we wanted to level up our practice management system. 10 minutes into the demo call and I was convinced. Use code Physio Coach 2MO, that's Physio Coach 2MO to get 2 months free. Sign up to the demo and see it for yourself. This podcast is a product of Better Physio Group, provider of physio and PT services in central London, helping people in pain, suffering with injury to feel better and live better. There's physio and then there's better physio. The thing with pendulums is that once they get moving, they keep swinging, and they swing from one direction to another quite slowly, more slowly than an actual pendulum, but the metaphorical pendulums will swing. And there is the temptation, as these pendulums swing really hard in one direction, that the baby gets thrown out with the bathwater. And that's certainly been the case with manual therapy. We have discussed it before on the show. We're going to discuss it again at the beginning of this show with Rodger Duckworth, physiotherapist by profession, but has moved away from that gently over time to reflect more of the work that he does. Complex case manager, therapist, working with people with long-term chronic illnesses, battling with his own identity on that, which we'll explore, and for clear reasons once we get into that section. But the early part of this episode is an exploration of manual therapy, quite philosophically speaking here, I believe. We'll talk about the sort of philosophy of manual therapy and touch. I think that's the key here is, I'm a dad with 2 youngish kids, and remember the advice that when your kids are born, make sure that you're getting skin on skin touch. It's incredibly important for development and connection with your child. Breastfeeding has all these benefits, and I think in part some of those benefits are touch with the mother. So we're pretty sure there, science has already confirmed the power of touch for development of a healthy relationship from even in the womb, from my understanding. So we know there is a power to touch, and yet for a long time we were taught, to me it feels around 10-ish years, there was a decade or so where manual therapy was disencouraged.
Sure.
Yeah. So there's reasons for that too, right? And this is why that pendulum was pushed and swung in the first place. There's some clear reasons for that. So Rodger, what's your take of it, and how do you come to terms and grapple with the philosophy and the evidence around manual therapy in your practice?
So, yeah, well, we'll come to how I don't really use manual therapy in a kind of physio type sense for much in my day-to-day work anymore, but I trained 36 years ago, and it was very much in a manual therapy era. There's been eras of electrotherapy, manual therapy, rehab. We've gone through a very long period of kind of exercise. And, if you put your hands on people, then, you're creating dependency, and it's taboo. And, mercifully, we seem to be, as you say, the pendulum swinging. And I think, we can come to the power of touch in my work in a bit. I think manual therapy, I've just seen work. And I probably saw it in a mechanistic way. And I think we began, and this is probably some of the criticisms that we go, well, look, are we really moving a vertebrae? Are we really moving a facet joint? The theory and the hypothesis upon which we used to operate with manual therapy is what has been questioned. I don't like proof or disproof really, but has been moved away from or questioned in a healthy way, as you say. And so I think because we live in this realm of sort of double-blind randomized clinical trials, and the research is absolutely everything, and we like proof, and egos get out there of going, oh, well, I've read the research and it says this, and so I'm going to do, and we stop being, to your point, philosophical about it, and actually just being experienced clinicians that go, well, look, something's happening when I put my hands on people. Now, I can remember actually doing when I was back in my NHS days, over 30 years ago, doing some training with people, going, well, what happens when we're doing manual therapy, when we're doing a lumbar rotation? What happens? And of course, I got the two expected answers at the time, which was, we're opening up the facet joint on one side, and the Mackenzie people all sort of said, well, we're mobilizing the disc and this, and then there was silence. And I said, okay, is that it? And I was a young physio. I was like 26 or something or other. And already I was then going, yeah, what's happened to the liver interface to the diaphragm? What's happening to the connective tissues? What's happening to quadratus lumborum? Are we really doing what? Yeah, are we? We're working with the muscular system here. Not to mention the fact that we're actually putting our hands on people, and we're doing something that says, hey, this body can move, and breaking fear avoidance behaviors. And oh well, gosh, if it can move like that, then maybe there were so many layers, I think, to touch. And what we know is, from certainly in the psychotherapeutic realm, is that the biggest predictor of outcome is the therapeutic alliance. And so the relationship that we have with our practitioner and between the patient and the client and the therapist is the biggest predictor of outcome. And that's certainly the case in psychotherapeutic modalities and body psychotherapy, but also I think in physical therapy. So, I think manual therapy, I've always questioned everything that I do. That's the way I am. And I'm very philosophical in that I go, look, if apples fell out of trees before Newton discovered gravity, are we going to deny that apples fall just because we don't have the research? Or are we going to be curious? And I often say that, we do a BSc, we do an MSc, and then we do a PhD, which is a Doctor of Philosophy. Philosophers wonder. Advanced scientists wonder. They don't sit on exact understanding. Science is the pursuit of understanding, not the understanding. But I think a naive scientific mind is one that goes, I must have proof. I don't know whether that answers that question at all.
Well, what you're allowing for is for the experienced clinician to draw on their experiences to realize that when they put their hands on someone and do a certain type of technique, it creates outcomes. That there are positive outcomes that come from that, whether they are short-term, medium-term, or long-term. To some degree, doesn't matter if you are using it as just one part of your therapeutic approach. So the point you make about the RCTs and all this evidence-based research will almost certainly be this single intervention, and it's doomed to failure in that realm. It isn't a single intervention. You can't use it as one. So you use it as part of your toolkit when you are working with someone. I always joke that I'm throwing the kitchen sink at it. And it's like I'm using the kitchen sink approach here. I'm gonna use everything I think might work with you, because I want to see you get better. I don't mind which thing in the end has the biggest benefit. I just want you to get better. It's the pragmatist way of looking at it rather than the researcher's way of looking at it. And unfortunately, pragmatic science is very hard to create. You have to do it in these kind of single intervention research projects,
like case studies difficult. Kind of things. But yes, okay, well, is that replicable? The problem is that we're individuals, and the standard model, as we were chatting before we sort of came on, that I talked about research-based evidence. And research-based evidence is only one form of evidence. We can call it, category A, B, or C, level 1, 2, 3, whatever level of evidence we wish to call it. And it's robust, but it, as you say, it's almost doomed to failure because it doesn't allow for the individual. And that we have this thing where we strip out all sorts of variables and go, well, they're a male between that age, and they're kind of, Caucasian, and they've never smoked in their life, and they kind of do 15 minutes of exercise a day, and da 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 da. And then we kind of go, and then they're all the same. Well, they're not.
Mm-hmm.
They're not. And we might get into transgenerational trauma, and there's a whole story that's going on in your DNA before you were even conceived. So they're not the same. And that's the fundamental error that we make when we try to put people in boxes to perform research, and then arrogantly, and it is arrogant in my opinion, then say evidence suggests this or evidence proves this. You will almost never hear me say the word proof, because there's no such thing as proof. There's only a weight of evidence at a point in time. That's all there ever is.
And yet you've moved away from it as an intervention to some degree, and you've landed on something a little more nuanced in your practice. You describe it as neurophysical touch, I believe. How do you then? How has it evolved over time for you, the use of manual therapy in your practice?
So I think with that questioning mind of thinking, okay, well, I was a physical therapist, I was trained a lot in manual therapy, but as I've alluded to, I'm questioning, okay, well, what am I doing? I began after training in physio. The first thing I did was train in Chinese acupuncture, and I was curious about that, and it began to get me to think about things outside of Gray's Anatomy and Guyton's Physiology and whatever other texts I might have studied. And again, I saw results, and I was fortunate enough to be trained in sort of more traditional Chinese principles, as opposed to just symptomatic pinpricking, as one of my other teachers called it, of pain-based acupuncture.
Almost the dry needling style.
Almost dry, yeah. To actually think about, and it introduced me to this idea of energy and qi. Now, to me, having studied conventionally originally, I kind of went, well, apparently there's this stuff called qi, and it flows around the body, and this is the principle upon it works. And I'm like, well, I didn't see that in Gray's Anatomy anyway, but anyway, I'll run with it. And it was very conceptual. But then over time, I then later studied things like craniosacral therapy, and started looking at fascia, and got ostracized by orthopedic surgeons for saying I was interested to the pattern. That's the thing, maybe to your question, observing patterns in behavior, the clinical experience that we're alluding to. If you are curious and as a practitioner, and you're really passionate and observing, you can't help but notice patterns in patients of like, why have so many people that get back pain got IBS? Why have so many people that have had a whiplash, do they develop hiatus hernias and reflux? Why do so many people that get frozen shoulders have a history of thyroid problems or chronic tonsillitis? If you ask the questions, but you see, this is the thing. As physios, we're trained to do that. I've started joining up things and going, I remember, we used to take medical histories, and you'd be going through, I just want to get through all this, get onto my objective and get into doing some treatment. And we'd sort of take the medication down, and it would be a matter of kind of professionalism. But there'd be no questioning about the fact that I don't. Okay, so apparently you're on thyroxine. Okay, great. That's hugely important to me now. Because, you're almost looking at it as a doctor. You're looking at it medically, holistically, dare I even say. Thankfully, I think we can come back to this space of actually going, no, holistic therapy really is not, some woo-woo Jesus sandals and a caftan. It is really what we should be doing.
Well, it's also more than paying lip service to a few questions, which I think is what you're alluding to there is, I need to ask about sleep. I need to ask about exercise, and I need to ask about stress. So, are you stressed? No, I'm not really stressed. Okay, great. I've ticked that box. And then you move on. It's that pro forma style of questioning, which to some degree we all have to go through at some point in our learning, because we haven't got the patterns in our mind yet. Mm-hmm. And I've now spoken to a few people, dare I say it, in your age, who seem to be able to to draw back, reflect back into their the decades of their career, and have this broad pattern recognition system, and that story of being ostracized by certain clinicians has come up a few times this year with more experienced clinicians. So it's clear that the expert sometimes has to be a little ahead of their time and be trying things a little differently before everyone else catches up and goes, oh, turns out there is something going on here. And that holistic, you were almost afraid to say the word holistic because it's been sort of bandied around in different connotations. But what we really mean by holistic is considering this multi-system effect of the body and the outputs that come with that, and then the inputs that drive the changes in those systems. So perhaps let's just explore those 3 examples that you just gave there. You said, isn't it interesting that people with low back pain have IBS? So let's start with that one. What's your what pattern does that connect for you for the listener to then go, I need to explore that more deeply next time?
Right. So, and this will tie in a little bit with my kind of, I suppose, thinking journey along the way, is I suppose, if we tend to think quite mechanically and physically as physiotherapists, the clue's in the name, right? Which is why I'm kind of moving away from the title of physio, as we've sort of touched on, because I am that, but I've studied many other things, and I'm just me. I'm just Rodger Duckworth, and I just bring me and everything that I've learned to meet the person. But I suppose I began thinking quite mechanistically, going, okay, well, what tissues connect? So one of the other things that I did along the way was visceral manipulation, and I studied the Jean-Pierre type work of studying the interfaces. I alluded to the liver and the diaphragm and things. So there are interfaces, and this is, well, of course, that then goes, oh, well, hang on a minute, yes, how is that? And then there's fascial tissue. And, it isn't just this thick, dense ITB that we might imagine. It's this 3-dimensional matrix, which, of course, now we're finding that has photons of light passing through it and information from cell to cell, which has no involvement whatsoever from the nervous system at all. And there's a communication taking place that doesn't involve the brain at all. Now, I didn't know that at the time, but I was going, okay, well, what? Okay, right, well, the large intestine and the small intestine are anatomically connected to their exoskeleton. So that was a sort of a thought. And even things like kidneys, and that's part of my own, I know quite a lot about kidneys because it's part of my own story, we might come on to that. But the kidney interfaces with the anterior aspect of quadratus lumborum and to the underside of the diaphragm. We have the transverse colon attached to the underside of the diaphragm at the splenic flexure and the hepatic flexures. So there are connections of these organs to the exoskeleton. And so it makes sense to me that we're going, well, if I'm moving this and it's not getting better, then maybe it's because that's, this the 3-dimensional pull idea of going, well, what if it's held somewhere else? And, this kind of, it's restricted down here. I move my shoulder and my shoulder hurts. This sort of somewhat simplistic principle. And I started to sort of think, well, maybe I need to then look away from the local tissue where it hurts, or where I might be feeling some local spasm, because that may be actually secondary to, and as you say, it's systems thinking rather than, parts, which we're trained to dissect the body physically. And I was fortunate enough to do actual dissection every week. And we're trained to actually dissect them. But then we forget to put it back into a system. So there was an anatomical connection for me between the bowel and the lumbar spine and the diaphragm and its connection to, and then that leads you into breath and breathing patterns and then stress and so on. So, that was probably where I came at it from a bowel, the IBS-y thing then. But it's not necessarily how I would look at it now.
And at that time, in that mechanistic way of thinking about it, did manual therapy then play a role in the way that you were taught viscerally? And, a colleague of mine, Simon Cabot, who's been a guest a couple of times on the show, also trained in the same school of thought and practices this visceral manipulation. Did that then shape this kind of evolution for you? And we'll keep it on manual therapy just for the moment as we discuss these cases. Did that then start to shape a different style of manual therapy there, I think, when you were thinking mechanistically?
Yeah, it did. And I think the thing that's happened a lot, to generalize, is I've become a lot lighter with my touch and a lot softer. And I think I was doing some training with my physio team yesterday, and I was reflecting back on he's probably no longer with us because I think he was nearing retirement age then, so he's probably in his well into his 90s now, if not no longer with us. But I did my advanced sort of high velocity manipulation stuff with a guy called Derek Stevens from London many years ago. And I remember at the time having a conversation going about, well, how does this work, and thinking about it. And I was looking at some books by Lewitt on the principles of manual therapy. And I started thinking of it very reflexively. So I think I started joining up the nervous system and thinking about, okay, well, neurophysio wasn't just treating strokes and MS and head injuries. This was like, well, no, hang on a minute. And it's all there, but we just go, hang on, dull moment really of, well, we just think about proprioception. Well, that's a nervous system based thing, but we don't think about the nervous system in any other way, and its relationship and its relation of the musculoskeletal system. And so I think that takes us potentially into touch, what touch is doing in terms of reflexive behavior, what happens. And then we've got things like trigger point type techniques and things and all the hypotheses around that. And we can, chuck that in or chuck it out, but it works. Yeah. And so, well, what are we doing with that? And then you get into you jab your finger into someone's QL, and then they usually get a spasm reaction back. So it ain't what you do, it's how you do it. And so what's actually happening, is this a kind of a yielding, is this a softening of the tissue in response to touch, which then leads us into a more neuro type touch.
Which is my experience. I get those local twitch responses as I've seen them defined. And I get the softening, and I get the reduction in pain and the improvement in movement, and the feeling that someone says, "Oh, I feel much looser." They feel different.
Yeah.
And that to me is incredibly powerful, and something that I will continue to work towards in those sessions. I'm looking for someone to feel different, and therefore make progress elsewhere. And whether or not that is sustained over time, I'm less bothered about. It's about in that moment. Does something change? Do they feel better? Because it gives me information, it gives them confidence, it builds trust. You were talking about therapeutic alliance, and it's hugely powerful for me to be able to change someone's pain in a session. And if they feel they need that more long term, I tend to then refer them out to someone else who enjoys it more than me. So I'm certainly using it as a tool, and it can be incredibly powerful. It's for different people, I think they use it in different ways, which I'm very supportive of. I think we hone our craft, and it becomes more artistic than scientific in those moments.
Agreed.
And you were talking about how yours has become more gentle over time. I think mine has become more gentle and subtle, and I move less. It's like so subtle with the directions I'm moving, and I'm feeling, and what's changing under my touch. Less of these big broad strokes over a body, more of a very specific point that I'm exploring over time, and I'm working with that person, monitoring their facial expressions if I can see it, or their body language, or how are they reacting under this touch. That's what I do get very into in the moment of really trying to explore what this person is, how this person is responding to my touch. And I think that's a really interesting difference that you're making there, the difference between perhaps this sort of big manual therapy techniques versus therapeutic touch.
So I think, to that, it's wondering what it's just exciting for me. You kind of go, well, wow, what is going on here? And I don't know, and I don't care in a way, but I'm curious. But when we're making touch, as you say, how does it join up with maybe some of the visceral stuff? I'm thinking three-dimensionally, and I'm thinking across the body. I'm thinking multi-layer. I'm thinking, okay, what is this doing? Oh, that's interesting. okay, so, and you start layering up. I did some great work with John Cross on, did a lot of energy work, or energy medicine training with him. He did, John, along with Nadia Ellis, were responsible for bringing acupuncture into the NHS and, back in the 70s and 60s, I think. And he got his Fellow of the Child Society for that. He's an amazing guy. I spent years of training with him. And layering up acupoints with trigger points, we know that there's a very high correlation, 75, 78% correlation between the two. And so to then go, well, okay, if our sort of frame of thinking through kind of Western thinking is pretty good, right? Helps us. But then when we get stuck, we have to go outside of that and go, okay, well, maybe the frame of thinking, not the way that I think this is have to do anything, but the way I go is, well, then I feel I need to go outside of my frame of thinking and then study it through an energetic lens or through some other sense of going, well, what if it's not just, is it mechanistic? Is it the fact that QL is actually having an effect on the kidney, and then might it actually be having an effect on the adrenal gland? Oh, that's interesting. I wonder what happens to the adrenal glands with chronic stress. I wonder if there's a relationship between the adrenal gland and quadratus lumborum. Oh, that's really interesting, because when I look at the two common trigger points in quadratus lumborum, then actually they are bladder 23, and so that's an associated effect point in Chinese medicine for the kidney. Isn't that curious? And I'm like, okay, so when I'm touching here, what am I doing? And it's a heck of a lot more than I think pretty much anybody has ever thought about. Oh, no, sorry, that's very arrogant. It's not true. Than many people think about. And certainly I think this is where to the I'm pleased, resurgence or reinvigoration of curiosity around manual therapy is, I think these are the conversations that we might, I'm quite happy to go, probably it's not the mechanistic lens that we thought it was. And yes, that probably needed to be questioned, but don't, as you say, throw the baby out with the bathwater. Let's just evolve the thinking in some way and go, well, maybe there is something about that. The other thing I wanted to pick up on what you just said there was kind of about that therapeutic alliance. There is something about fear avoidance behavior. And, yes, if we get a change in someone's behavior and they go, oh, I feel better. One of my colleagues yesterday was saying, okay, so what was the power of that? And he sort of said, well, one of the things is he picks up on that and he goes, you see, there's potential there. Yeah. It's possible for this to not hurt. It is possible for you to move. That psychologically kind of goes, great. And it removes a lot of the fear in and of itself. That may take away bracing and armoring that says, my back's is like fragile glass and it's going to break. And we start, we go on this sort of vicious circle downwards, and our job is to basically reverse that circle one way or another. And if we can do something using touch, which actually creates a shift for the person to make them feel that their pain can possibly go away, then I think that it sows a seed of doubt in their mind of this, and actually less a seed of doubt, more a seed of hope.
Hope, I was going to correct you there. Yeah. I was just waiting for you to finish, because that's exactly what I'm looking for. Can I get this person to leave feeling hopeful for their recovery? Yeah. And and the line often is that I've just created change here. If there was anything more sinister structurally going on here, this wouldn't have changed anything. This wouldn't have changed anything. But now we've created this change, I am more hopeful. I'm more optimistic about your prognosis going forward. So great. I'm really excited for the next session. And when that person leaves, they feel hopeful. And I think that's such a powerful experience.
Absolutely. Literally did that yesterday. And I was working with somebody with migraines. I was working online with him, actually. And he was in migraine in the session. And actually, at the end of the session, he kind of went, oh, my migraine is like at least 50% better. And we're nowhere near his head. We were just sitting there and working with various kinds of things somatically in his nervous system and tracking patterns of behavior, embracing and overwhelm and things like that. And so, and I said to him just that, and it was only session 2. And I said, well, there you go. That's really reassuring to me that we're on the right track here. Yeah. Because if we can create that change in migraine right now, it suggests we're hitting the right kind of things here that are the cause of your migraines, and we just keep going, and there's the hope.
Why is a hiatus hernia linked to whiplash?
Well, it's a good question. Mechanistically, I thought, and it ties us back into the visceral world, if we get a high velocity extension pattern, a couple of things that are likely to happen. This was my original hypothesis. I think there could be other reasons as well these days. But mechanistically, if we get a hyperextension of our cervical spine, it's not just our cervical spine. We've got our trachea, we've got our esophagus.
We even heard your voice change as you did that, which helps the listener almost kind of experience kind of what happens in that moment.
You kind of go, that's really difficult to do that. And then and there's a bracing here. Of course, we've got all the platysma, scalenes. There's a whole structural thing starting to influence on that. So it does tell you, actually, there you go. If I do that, then is that going to change the tension on my larynx? Is it going to change the tension on my thyroid? Yes. Might that affect the efficiency and the health and well-being of that structure, and therefore its endocrine function? Yes. But coming back to your question about that, the other thing that's likely to happen during a whiplash, particularly if we've got a seatbelt that's bracing us down here with the horizontal aspect, is also a respiratory bracing. So we've got a point. So our esophagus is comes down and then pierces through the esophagus and does a left turn at the gastroesophageal junction into your stomach. And so at the point that we've got a diaphragmatic bracing, a downward movement held by a physical seatbelt, at the same time as a hyperextension of thoracic spine in there's a big wrench of the gastroesophageal junction. Basically, hiatus hernia is a failure of function of the gastroesophageal junction and the sphincter there, the cardiac sphincter at the opening of the stomach, usually then not closing. Now, as I say, it could be whiplash, but of course there's also shock elements to this. So I could then say, now, what about the autonomic nervous system? What about trauma? You've got that physical trauma to that area. Even if it's not whiplash, then things like reflux, etc., and going with stress and trauma might be our friend the autonomic nervous system, because guess what controls this cardiac sphincter and pyloric sphincter at the entrance and exit to the stomach? Our friend the autonomic nervous system. And so if we get trauma which dysregulates that, might that have an influence on the visceral function? Yes.
Something our customers keep telling us about Jane App is that she is really good at reminding them about their appointments. Quite persistent at times, but as a result, people do keep turning up to their appointments on time, on the right day. You can set how many times the reminders come out. You can set the wording in the reminders. And as a result, we have seen a significant reduction in the amount of late cancellations and non-arrivals. So if people can't make it, they let us know with plenty of time. And people get reminded on the day, so they often do turn up. They don't let work get in the way. We're really pleased with it. Works really well. One of my customers has even started to refer to Jane as his PA because she's so good at keeping him organised. So yeah, it really does seem to work well for that. And now back to the episode. How would trauma start to cause dysregulation of the autonomic nervous system? What's the thing? Or how do so I love this stuff. Most of the regular listeners will know that I'm very interested in this world. How do you then explain that? More importantly, how do you explain how that dysregulation happens to a client who's never heard of the autonomic nervous system?
How might I go about explaining it to them?
Yeah, because if you speak that, then what I think might be helpful is the listeners then got some phrases or some tools that they can then share that. Because as much as I've heard this stuff before, it's great when I hear someone give an explanation that's more layman speak.
So I'll often say, even if we move away from necessarily the viscera or what have you, but let's say we're talking about trauma generally, and I say, okay, so we have an unconscious part of our nervous system. So a lot of the things which govern the activity within our body is controlled by something called the autonomic nervous system, automatic, so that you don't decide to make your pupils dilate, they do it. You don't decide necessarily to increase your heart rate, it happens. Yeah. And so we have not quite a plus and a minus, but we have something which causes increase in charge in the body, which we call the sympathetic, and then the downside we call the parasympathetic. Parasympathetic, I always think, is like a parachute comes down. Sympathetic goes up quite fast because it's myelinated, so if it goes up like a rocket, it comes down like a parachute. So now this links trauma-wise to, well, this links to the body in terms of it's not always bad. It's not always trauma. You know, if I need to run upstairs, I need to say, right, I need more activity in my heart rate. I need to pump some blood through into my lungs and into my muscles to undertake physical activity. I'm going out for a run. I'm going to the gym, doing whatever it is, right? Okay, that's normal. It should then swing back down again into what we call rest and digest, which is, okay, right now I can shift my circulation into the stomach and get gurgle, 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 and my heart rate can come back down again. It's what would be called yin and yang in Chinese medicine. Homeostasis, to any of the physio type listeners out there, is in Western medicine. So that's normal. It's healthy. That's in capacity, and it's there's no trauma involved. So really, it's that plus and that minus, you know. And I'll often use analogies to the client, to the patient, of saying, look, it's really the principle of, say, butterflies in the stomach when you've got an interview or an exam or something, because what's happening there is you are getting fasciculations. You're getting changes actually in the stomach more. You're getting changes in this cardiac sphincter, in fact. That then says, right now we don't want to digest dinner because there's a stressful situation and I might need to get up out of the interview and leg it. All right. And so we're preparing to do that, to take fight or flight. But also that sense as clients lie down on the couch and maybe go, oh, I'm terribly sorry, my stomach's going. I go, no, it's a good thing because your system's relaxing. Yeah. It's an indication to me that, well, okay, might be some kind of postural thing that you're lying down and there's a gurgle, but probably it's actually that your system is dropping, and that's a good thing. Please don't apologize.
Take it as a compliment.
I do. I'm going, we're getting something right. Yeah. So that's how I might kind of describe normal autonomic nervous system function to the layman.
And then trauma comes along, and we won't necessarily cover that fully yet, but how does that then shift the nervous system into dysfunctional dysregulation? Yeah.
So trauma seen through this lens and through a nervous system lens, as opposed to orthopedic trauma, I was hit by a bus. Nervous system trauma is defined as anything which overwhelms that nervous system's ability to cope. Yeah, it is sometimes seen as this river, a window of tolerance, as it's often called, you know, where you can go, I've got higher charge, I've got lower charge, and often what I will describe this to patients as is, it's like the river and rain. It has a capacity and it can cope with increases and decreases in the amount of rainfall and water entering the system. But too much, too fast, too soon, for too long, or in the case of neglect, not enough, then what will happen is that the capacity and the tolerance of that river is exceeded and it floods. And so what that leads to is what's sometimes called a trauma vortex, which could be high charge in terms of sympathetic overwhelm, which goes into our fight, flight, and high activation, and that has a particular pattern, and or the opposite side of going into, well, actually, what if I can't take flight and I can't? Then I might freeze, rabbit in the headlights, or I might flop. Yeah, and there's lots in the animal kingdom that indicates this. Where, you know, the gazelle kind of hits the deck before the lion sort of sinks his teeth into it. Now, part of that we know is actually a physiological response, because there's huge amounts of opiates and endorphins which get dumped into the system to go, well, if I'm about to be torn limb from limb, I'd rather not know about it. So we dissociate, we zone out, we split, and we get a massive biochemical rush that just goes, well, let's make it hurt less. So there's normal, there are people that are questioning, well, is that trauma or is it? These are natural responses in a way Now, the difference is when you look at the animal kingdom, they will often go into sort of freeze responses, but it's a question of whether they come out, how they come out of it, and whether then they so-called process that trauma. You probably, because I know you're interested, you've probably seen that famous one with the polar bear, and he gets anaesthetized and he tremors as he comes back out of it. And this is where we get into things like TRE, trauma release exercise, which is something else I've sort of explored in the past. Don't really use it very much now. It's a bit blunt instrument, really. But yes, we may get discharge of that if we allow it through. And there's something interesting, and I don't know the answer to this, but it's an area of my kind of exploration really, is to, well, okay, so why is it that humans don't do that? I have some thoughts on it. Discuss it later if you want to, but why do humans just get stuck with this? But trauma therapy really is about trying to go back to look at what the body had to do with it when it once met that overwhelm. This can lead us into so there can be single event shock trauma, but actually it gets very interesting in a lot of my work these days with developmental trauma, because that's where we go, well, actually, when we're learning the patterns of our nervous system, of what we do, as we grow, then every time we meet this experience, and that might be an emotional experience, it might be what I come up against when I feel angry and how anger is handled as I'm growing and evolving. My nervous system has a charge. If it meets the boulder and every time it goes right, that's what it's going to do every time it does it. And it's just a pattern. And when we're into, our work is really potentially around neuroplasticity and retraining neuroplasticity.
And it's automatic. That's the key.
Yes.
That's why it can be so challenging for people, is that it's, especially developmentally, if it's so long ago, so automatic. That's the challenging work that you have clearly evolved into in your career. Because
it's not conscious necessarily. And again, I like analogies, and people go, well, you were sort of saying, oh, well, I haven't had this time. And people go, oh, I haven't had trauma. And I go, well, you have, because nobody gets through life without trauma. And actually, it's amazing how many people kind of think, no, I had a great childhood. Nothing bad's happened. And then you find, and you kind of go through it, and you see that was their only frame of reference, and they think that's normal. And I go, well, oof, that's a lot. Or actually, they don't think it, but then when we're working and we're tracking their physiology, and I'm going, well, let's just chuck the label trauma away, because if it's getting in the way, well, let's just not worry about it. But just go, let's look at what's happening in your body. And as we talk about this thing, I notice that there's just something's changed in your skin tone in your face, or I just noticed that your eye gaze just glanced away, or I noticed that actually the foot started fidgeting a bit more, or that actually the tone in your traps just changed as we got into that difficult conversation. And I was just wondering, I'm curious whether that actually relates to a bracing and a holding that might have something to do with this chronic neck pain that you've got. Because if we've got something and we're going, you can't say, sorry, I'm bouncing around all over the place here. But again, we're having a conversation with, I've got a physio who used to work for me, who's potentially coming back to work in my practice again soon. It'd be great. I was chatting with him the other evening, and he's working the NHS, and they all want one session, and it's just triage them and send them on and reassure them, and they get better. And I go, well, look, if lots of people get better on their own, which we know they do, if you don't really do much and you reassure them and give them some exercise, a lot of people do. And I go, yes. And I've always been curious about the 10% that don't get better. Because really, that's what we need to get good at. And actually, we can pat ourselves on the back for the ones we get better. But actually, if they're going to get better anyway, are we really doing much as a clinician? And I said, so my interest is in kind of going, how many clinicians are actually any good at dealing with the stuff that no one else gets better? Well, actually, that's where we should be going as clinicians, in my opinion. And that's been the journey that I've gone, is going, well, okay, they're going to get better anyway. I want to treat the people, going, these aren't getting better. Some of my patients have had problems for 15, 20, 30 years. That's not going away. And so being able to, we get into tracking the system in a different way. Because how do you know where you are in that autonomic nervous system isn't just something which is thought about. It's a felt sense experience. It's tracked through sensation, through image, through smell. I remember a smell of something's coming in right now, and as I do, then I notice my heart rate's gone up. It's a real qualitative human tracking emotion. Oh, that's interesting as you say that, right? Okay, oh, you sound as though you're getting really pissed off right now. So it's tracking that whole human experience through things which are automatic and in the unconscious nervous system, as well as the narrative. And that's where it's slightly, no disrespect to this is I don't mean this disrespectfully to psychotherapists, because they're excellent, and many of them do track a lot of body language and signals, but much of my somatic experiencing training was with psychotherapists and counselors, because what they're realizing is that you can't always tackle things from the top down alone. There's no amount of going, oh, that makes so much sense. Now I know why I hit the deck when I hear a car backfire as it goes down the road. It's because I was in a war zone. Well, how does that change anything? It doesn't. So how do you work with it? It's not a cognitive process, and that's why the autonomic nervous system is so important to work with.
And what you're doing in the moment is being incredibly sensitive and curious about the person in front of you and how they're responding to each and every part of the session, which is the expert clinician, and it's the stuff that we're trying to teach. Is there isn't a simple moment in time where you suddenly go from NHS physio early years to being incredibly sensitive and have all these amazing patterns in your mind to pick up on this stuff, and work with the person using expert communication and therapeutic touch and multi-system approach, the genuine holistic care. There is an intense curiosity and connection with the person that helps you get there.
Absolutely.
But how did you get there? So let's go back to your beginning. How did you get there over your career? Tell us about the beginnings of your physio career.
Well, I became a physio, if I go way back to when I was 10 years old, and my mother got Guillain-Barré syndrome, and really bad at the time because she was completely paralyzed, and actually unusually she went blind, which for anyone, if they're listeners and they're anatomically trained, should know that shouldn't happen, because that's a cranial nerve, and Guillain-Barré doesn't normally affect cranial nerves. Anyway, it has subsequently found that occasionally that happens, but I think she was the first on written record at the time. So I'd also been involved in myself. I'd had 7 operations under the age of 10. I was born with 2 kidneys on this side and 1 on the other, and all sorts of complications. And so I've had lots of anaesthetic trauma, which interestingly in my training I kind of discovered that it wasn't until about 1980, so after all of my surgery, that they mandated in the UK that anaesthetics contained analgesic. And so, yes, they anaesthetised you and they knocked you out, but they didn't actually put any pain blockers in at all, because they didn't believe that babies could feel pain. So all of my nervous system unconsciously was experiencing the incisions and everything that ever happened to me. And interestingly, in my own trauma training, that came out quite a lot. And so you go, that is amazing how that is stored in the system. So, but that was later in the journey. So hospitals and medicine had saved my life, and I spent a lot of time in them. And so I suppose it was natural that I went that way. My father was an engineer. It's quite practical, so I like using my hands. And then my mother got Guillain-Barré, and I saw physios really, she had this expression that, the doctor saved my life, but the physios gave me my life back. She had to learn to breathe, hold her head up, speak. It took about 5 years of rehab to get her back, and she's 92 this year and still going. So that's pretty incredible. So that was probably my intro to physio. And then, prior to this podcast, you were like, well, yeah, I'm really interested in what moved you away from physio. And so, my own lived experience, our greatest teacher is ourselves, right? And our own journey and our own experiences, and the great challenges that we've gone through our lives, either in our relationships or, the best time to be a parent is when you've been one. My kids are now more or less grown up, and I'm like, oh, tell you what, I say to my wife, I wish I could be a new dad now, because I think I wouldn't mess up as much. And that's the point. We have to have our own lived experience. And so when I was, I never get emotional on this one because I often do. I was doing some teaching recently and I told it again and just got very emotional. So anyway, it might happen. But, I can remember my daughter, my son wasn't born. So we're going back 21 years. And my daughter was about 18 months. And I'd had this ongoing issue with horrible chest pain, fevers, coming and going episodes. I'd been to my GP. They'd said, "Oh, you've got pleurisy or you've got flu," and I was like, "No." 6 months in, I even went to my GP and said, "Do you think I've got relapsing pericarditis?" And he went, "Nah, your ECG is normal. It's not that." And I was like, "Okay, you're the doctor then." Another 6 months later, after 14 episodes in total, it got worse and worse and worse to the point that I ended up collapsing in a heap on the floor with crushing chest pain. Big thud, and my daughter came running into the room going, "Daddy, Daddy," and I just screamed to my wife, "Get her out, call an ambulance," because I didn't want her to witness that. And so I ended up in coronary care. I had probably the largest pericardial, well, he said it was the largest pericardial effusion he'd ever seen, which was about 2.5 centimetres either side of the heart, crushing my heart in the middle. And I got something called cardiac tamponade, which basically just meant the heart couldn't operate, flatlined. And so, mercifully, I was in coronary care at the time, and they went, okay, it was a morphine overdose as well, give him some naloxone, and they got massive steroids, got the swelling down, and I'm here to tell the tale. But the problem I had was that every time I tried to come and titrate off the steroids, which, all right, to be fair, steroids are tricky things to titrate off anyway, but every time it came back, the swelling came back for a long time. And then it got to this point where actually I managed to come off, and I went back to the cardiologist and he said, "Well, I did another echocardiogram." He said, "Well, that's fine. That's weird." He said, "There's no scarring, there's no swelling." He said, "But you're still in pain." Interesting. So I got a chronic pain pattern in the absence of the edema. Interesting. So then I had to go, well, why is my body inflaming itself, and why am I still in this pain? And then really that was a sense of, well, he kind of went, "I can't offer anything else. I could stick you on metformin or something or other, methotrexate, and I was like, "Oh, I don't fancy that." So it was, all right, better figure out and physician heal thyself. So that was my journey, really. And I suppose going back to manual therapy and thinking about some of the wisdoms from chiropractic, and I was thinking, well, I've seen these patterns with other people, that maybe the thoracic spine, sympathetic nervous system involvement coming out from the dorsal root ganglia there. What's going on? And my T4 was really, T2 to T4 was really sore, and that's kind of, cardiac plexus coming out from there. So it was some involvement there. But then I was realizing that, I got a busy practice. I was under a lot of pressure. There was stress. I was kind of going, I knew I needed to still my chattering mind. At the time I was doing yoga, and then I kind of explored martial arts, took up Zen philosophy, and began to really tune in to start to joining up mindful practice with somatic self-awareness, tracking, noticing the patterns of tension within my own system, within the fascia or wherever else it was. Energy flows through my body, and I just found this journey of figuring out why my body was inflaming itself. And it took me about 8 years. I went through various forms of psychotherapy, some good, some not. And eventually happened on a good psychotherapist. And just a blending really of self-work, deep self-personal reflection, joining up the psychological work with its impact on the body, considering looking at different tribes and all of the ways in which they dealt with trauma. I've been on a long journey.
And long journey sounds like the key message there for someone who has gone through significant trauma, near-death experience trauma, correlated with a high-pressure life at the time that then drives this, again, multi-system, automatic symptomology. And you then, you were a skilled practitioner at that time, and you said 8 years. It was 8 years, you said.
What, to recover?
Yeah. 8 years.
Yeah.
And yet we still talk to people in months.
Yeah.
We say, okay, well, I think you'll be better in 3 to 6 months.
Yeah.
You're here telling a very different story of that. And my experience working with people with chronic pain and other complex cases is that I tell them this will be many years sometimes, and we'll see some good progress over time if things are going well. But there's a really good chance this might take many months and years, and that's okay, and that's normal. And there's often an acceptance of that quite easily for someone who's been in pain for many years already. They kind of get that intuitively, that, well, it's taken this long to come on. Well, I get that. It's going to take that long to drift away. So as difficult as that story was clearly for you, and what a wonderful journey it's been in the end, and clearly it shaped your practice, incredibly traumatic at the time, no doubt. But that's the thing that stuck out to me there, is it was 8 years. Yeah. And yet you're still doing it, bits and pieces of it, right? You've still kept many of those practices to this day.
Yes.
Because it's worked.
Yes.
So they become forever treatments in a way.
Yeah, it becomes a way of life in the end. Yeah, because I think we have to look at ourselves and go, okay, well, what am I doing to perpetuate things, to create things? And yes, it might be the product of things which happened to us, and to the kind of the famous expression used in the trauma world, which is, trauma's not what happened to you, it's what happens inside you in response to what happened to you. So, there's the parent pieces and developmental pieces. I had all sorts of things which happened to me. My parents were pretty good parents. I did not have an awful childhood, but I do have elements of my childhood which later I realized were very contributory to the patterns which played out in my adult life. And I suppose, and this is where I've had to go on and train in other modalities and neuroaffective touch, somatic experiencing, developmental neuropsychology, body psychotherapy, various forms, because to be able to, you realize that it's people's relationship pieces come in as well, and they suddenly go, look, that's part of the bigger pattern. You suddenly go, right, all these people, and my own near misses in my own relationship and marriage of a relationship of 36 years, you go, actually, how does what in the psychotherapeutic realm will be called transference, or sometimes overcoupling and things like that, why do we respond the way we do now based on what happened to us in the past, which shaped our nervous system then? And so, this can be going into things like people pleasing. What happens? I spend, there's barely a day goes by that I'm not working with what we might call overcoupled anger and shame, for example. So an example there, it would be, let's go back a step. I mentioned felt sense before. So, when we have an emotion, for example, we go, well, people say, oh, I feel angry. And I go, okay, how do you recognize that? And I use the word recognize, not know, because I want to move them away from cognitive. I go, well, how do you know that? Oh, just because I'm frustrated. Okay, all right. How do you recognize that? What's the quality of that? Is that, how do you feel? Is that, and they see whether they can then track a sense of, well, what does that feel? What does that, it feels like my energy's up top. I'm really, really wound up. I'm really frustrated. And it feels actually like the energy's up top and my legs have gone a bit fidgety and there's a fizziness in my hands, or there's a quality that we recognize that comes up and filters up. And we would have had when we were babies before we could even speak. We happened later to learn the English language that went, oh, that's anger. But it's an experience, which is why I actually think Peter Levine's term somatic experiencing is a wonderful one, because it's like it's wonderfully vague, but actually beautifully encompassing. The experience of something, and then we work with that. I might call it a charge or that energy, and we can sit. And I'm not to any physicists out there, and actually, we know that there's energy. Heart math have shown us that there's electromagnetic energy fields that radiate. Right now, all of our heart energy is actually overlapping and communicating with each other. And I'm wandering off again, but I heard some interesting. This is known in lots of ways. Tribes knew it. They understood the power of collective. They would never, ever dream of allowing someone that had been through traumatizing experiences to do that alone. And trauma, we often feel alone, even if we're not alone. So when in theatre, here we are, close to theatre land, directors know that it takes about 12 minutes for the majority of the audience's hearts to synchronize in beat from the commencement to the start of the theatre show. Because they're all sharing a collective experience. Really interesting. Mm-hmm. So emotion is important for us to work with, and what that charge is and meeting that charge. But if, for example, coming back to my thread, I'm terrible at this, sorry, Charlie, but I'll try and hold the thread. If when we have anger as a child because, we're woken up in the night and we're going, where are you? And we're tiny or whatever, or we, get angry with our sibling because they've pushed us or taken a toy, or we want a biscuit. Mum said you can't have it because dinner's coming, and all of the usual stuff. Depending on how that's handled, that will shape what we do with that charge. Now, if we get hit, if we get scolded, if we get disconnected or feel a sense of disconnection of sent to our room, or kind of it's not handled well, or we are told that we're shameful for lashing out at our brother or whatever it is, then actually to the small child, it's not possible that the parent is wrong, because they're the only frame of reference. And so there's only one possibility, that if they're getting told off for this all the time, or they get hit for it, then there's something wrong with the experience. And actually that translates into there must be something wrong with me, which basically is shame. Now, fast forward to being an adult. If that pattern is there, healthy aggression, as I prefer to call it, which is important for no, back off, I don't like the way you're speaking to me, leave me alone, or actually that really hurt me. No, Gabor Mate's body says no when you can't say no. This is why anger and healthy aggression is so important, joining up these dots of these wonderful pieces of work from Gabor and, Bessel van der Kolk and people like that. Body keeps the score. If that anger comes up, it sort of transmutes, or what we might call overcouples in somatic languaging. It transmutes on the way up and goes, no, I can't have that because it's going to lead to that horrible sense of disconnection, so I am going to bury it. And usually what happens is it leads to a sense of self-shame. So we get that shame feeling. So every time I feel that, I feel bad, and I'm a bad person, which can often lead into self-injurious behaviors like eating disorders, addiction, self-harm, etc., and or people-pleasing behavior, altered attachment. And so this is where we get into attachment theory, people-pleasing behaviors, which then mean that people then don't actually express their no, which is hence all Gabor's work of kind of going, well, actually in your relationships you never say no, and then that anger gets directed as an energy that's stored within you, leading to dis-ease. Sorry, there was a lot in that.
There was a lot in that, and I would actually encourage the listener to wind that back and listen again, because I think they'll hear something else in it. To listen to that again, they'll hear more. Mm. So go back to that, maybe 5 to 10 minutes perhaps, listen again and get something else from it, because there's a lot in there. Some of those book recommendations, I've read all of Gabor Mate's, not all, but certainly some of his bigger works. I'm currently halfway through The Body Keeps the Score.
It's a big book.
Yeah, and I'm very much enjoying it. And I've just read Robert Sapolsky's Determined, which I've actually found quite challenging to read. Not necessarily because the science in it and the theory and the philosophy wasn't very interesting to me, but I sort of agreed with him from the beginning, and I just didn't really. It wasn't changing my mind very much. It was sort of I was just going along with it. Like, I sort of get this, but what do we do with that in the world? Because we experience this concept of free will, and that we don't have free will technically, and that's true. We don't technically have free will, but we feel like we do, and it's this sort of mirage of free will that actually helps us live a life that we want to live. And I find that very interesting, and it was. But I just sort of believed it the whole way through. It's like, okay, yeah. So you just keep telling me the same argument that I already believe in. But anyway, a lot of that is very much linked to what you're saying there, and certainly the stuff around childhood development. And this is where I think it'd be useful to discuss the ACE study, which we have talked about before on this podcast. But this is why it's important that we understand this as therapists, that it is so predictive. It is such an important piece of work that we should keep mentioning it. So how do you consider that in your practice?
It comes up in conversation sometimes, and these pieces are sometimes little tidbits that one shares when relevant to a client, and or sometimes not that we're trying to convince, but that it makes people think, that we go, well, it is aligned with trauma's not what happened to you. It's what happens inside. But it goes along with that if we go, look, if the sheer fact of the matter is that if you've got an ACE score of 3, and I can never remember all 10 of them, but let's say one of your parents is abusing drugs and alcohol, the parents lead it to a divorce, and perhaps you witness some kind of domestic violence or something or other, or somebody within the family had mental health disorder, they were abusing drugs and alcohol, and then the parents split up.
Which isn't that unusual?
It's not that unusual at all. Yeah. So that's an ACE score of 3. If you've got an ACE score of 3, you're 386% more likely to die of a heart attack and a stroke in later life than if you don't. That's nearly a 4-fold increase in the risk of frank physiological, biological change in response to the childhood adversities. Now, we really have to just put a bit of a mic drop, pause on that.
Biopsychosocial, capital letters on the social, and underline it, please.
Yeah.
It's like that. You cannot dismiss the social when you hear powerful stuff like that. It is just too impactful on someone's life to just focus on the bio there. Like, you're just going to miss the wood for the trees, right? You've got to understand the bigger picture.
Yeah, and and so often, I think that now as practitioners and therapists, that we are educators to our patients, but this notion that pain equates to the tissue must be damaged is still there in the psyche of most of our patients.
Yeah.
And I think just sometimes to actually share that and say, well, look, you go, wow. You go, you see, we're not just this biological machine that is just doing its thing, disconnected from its environment. And then we get into epigenetics, another area of the whole epigenetic field is an area that I spent quite a period of time sort of doing a deep dive into, because that felt important as well, and it's linking so much with these ACE scores. We are the product of our lives. We are the product of our environment, and we can't unlive our experiences. And so trauma is very big these days, and it's all like, oh, it's trauma. Sure. How much of this is going on now? It's another area of interest. Why is this just because we're understanding it now? Was so much of the stuff that people were getting sick with before, but we just had this sort of biochemical view of, well, it's type 2 diabetes, and so it's your diet, and it's this, that, and the other, and it was just, maybe we're just getting a little bit like my practice in a way. It's just becoming richer of going, no, actually, we were just so naive that actually, yes, but then, I might look at it and go, well, But why are you comforting? I mean, I've got people working with disordered eating and things. Well, that's part of the pattern that they come with, along with all of their other things. I'm going, well, what do you do? I just meet people, and I meet whatever they bring, and whatever presentation that they bring, and well, I comfort eat. Okay, why? Well, then let's get into the kind of and it might be, well, not why, and we'll go, well, I comfort eat because I feel rubbish. If I can help people work with the fork in the road of the pattern that comes up that goes, well, I feel whatever it is alone, or I feel stressed, or I feel this charge coming in my body. What if I can help you through neuroplastic training, help you go, when you come up to this point that you go, well, I didn't have anything that allowed me to feel settled with this, supported, and so I felt alone. And what I found was that if I comfort eat, or I do something, or I take a drink, or I take a heroin shot, or I self-harm, or I go and run and go to the gym 7 times a week and overdo it, and any other kind of what we might consider to be a more healthy addictive coping strategies, some slightly less destructive, but there's still behavioral things which, if anything you do to excess, can be problematic, even go to the gym. Then what if I meet that pattern and they go, that's the experience, and what if that was the only way that you could cope? What if I could support you and help you to have a different process within your autonomic nervous system, within your human experience, to allow that to be different? Now we can be getting into attachment pieces, and it might be, you'll just feel somebody just pull back a little bit or disconnect, or their eye gaze go at some point, and I'm going, there is the point where I've just met some kind of attachment trauma pattern where they've just gone, I have to be alone. At which point I might just be able to come towards them and put my foot next to their foot, or just go, I'm right here. And that's the first time. And then they go, that part that feels like that. So we're into Dickie Schwartz parts work here. That part that feels like that. Does it know that I'm here? Yeah. Is it all right? Is it scared that I'm here? Is it reassured that I'm here? Yeah, it knows you're here. It's okay. Thank you. Tell it thank you for trusting me to be here with you right now. These are the things. This is where we are in my work.
There's a separateness that you're describing there. You're almost encouraging a separateness of the person to the trauma.
In some respects,
and yet togetherness, right? Yeah. That's the paradox I'm just curious about here. Is that you're talking to it, and yet it's part of it and part of the person.
Yes, and then we get into the realms of actually there can be this sort of identification, or as we would call transference or identification in psychotherapeutic language, or overcoupling. And sometimes if we can have this sort of bird's eye view, because what can happen is we become so identified with it, so it's like we sort of, if we get into the vortex of it, that it's there are, that's a tool, it's a way, but we could look at that through, is it attachment? Am I disidentifying something, uncoupling something? Yes. Which therapeutic approach do we want to look at this from? Don't mind, don't care. I've learned from all of them.
Kitchen sink approach again.
Kitchen sink. I've learned from all of them, and I could call it that, or that. Yeah. The point is, I'm just doing it.
Yeah.
And I could theorize it, and I could teach it, but in the moment
you're plucking the pattern recognition that works, the thing that's experience has led you to realize works for the person in front of you based on what they are bringing,
and even intuiting something. And there's another whole series of podcasts around intuition and actually tapping into that energetic field. And there's stuff around the gut right now, and the gut intelligence. And actually, we know when someone's walked into our personal space, or we get a vibe off something, or we feel the mood as we're going through it, as we talk about it. We're like, the mood has changed, and I can tell you're sensing it. And here we are. And it's like, ooh, and we sense that. That's part of our skill as a therapist. Any practitioner working with another person, psychotherapist, physiotherapist, physician, doctor, doesn't matter. And I think we need to be curious about that. And it's a skill we must hone. And when we can, I think there's a richness. There is so much so much more. I really feel, I can really feel that actually in my own heart. As I say, there is so much more richness when we open our eyes to the human experience that we have the privilege and honor of being entrusted to work with.
I feel that. I feel the same. I feel the same. Yeah, the warmth is just lifting up in me, and that's what this podcast is about. Is inspiring the learning journey of the listener, whoever they may be. And your journey started with, firstly, a curiosity about the profession, driven by your childhood experiences, but then became quite a hard shift based on the significant traumas that you had. And what's left is this expert practitioner that we're obviously discussing some of those wonderful methods that you have and all those different tools you have at your disposal to figure out what's right for the person in front of you. What's the middle bit there look like? Because there's I guess there's almost this intimidation of like,
how do I get there?
How do I get there? That's pretty cool.
Ooh.
Without maybe going through the trauma that you had and the 8-year struggles. Sometimes, as you say, like, we're always a better practitioner for our own traumas and our own struggles. Yeah. We're usually better at injuries that we've had before because we've had that lived experience. But sure, I think there are still some overarching learning points that people could take.
Yeah. Don't wish, quite frankly, anyone to have to go through what I went through in order to grow as a practitioner, and you don't need to. Mercifully, we're in a world where all this stuff's out there now. Bessel van der Kolk hadn't written the book. He's only written the book about 12 years ago. I was healed by then. I was done by then. Peter Levine's work was there, but not really being taught very much in the UK. So, it's like, I had to figure it out. I had to figure it out myself. And then later, like so often, I kind of go, well, but go and get a piece of paper to say that apparently I can do it. And I'm not saying I didn't learn massively from then the more formal education in lots of these other things. Of course I did, but they were springboards of kind of going, oh, well, that's what I need to learn. And how can I either practice that myself? And are there spaces I can go to actually then train myself so that I can know how to do that even better, or go through my own work? I mean, crikey. I had years of psychotherapeutic work. I would recommend that, quite frankly. That would be one thing that I would do is if you're interested in this, go and do your own therapy.
Yeah, I've just started myself. I started this year, late last year, and it's been a really interesting experience for me because I went into it not suffering. I wasn't suffering with anything in particular. I was deeply curious about how I can feel more. Actually, we were speaking earlier about your how you've observed with some people dissociating from certain emotions. And I also look back on my childhood and think I was pretty normal, it was fine. I felt safe and I felt supported. But there was a distinct lack of emotion that was discussed within the family. We didn't speak about our feelings. And that has certainly shaped my life. And it's both been a performance enhancer for me, but also at times it's been a limitation for my growth. And that's what my therapy has been about this last 6 months, is to explore feelings. How do I get more in touch with what my body is feeling rather than being stuck in my head all the time? Because I'm very good at rationalizing and being logical, and you probably not surprised
we're all the
by
same.
that, right?
Yeah, but we're all the same. It's a part of the human experience. I mean, don't beat ourselves up about it, because we just do. But I think there's a term we use a lot in the kind of the somatic world, which is you just notice that.
And that's what I've enjoyed, is to notice things that I hadn't noticed before, and to have feelings that I hadn't had in a very long time that were really, really good. I've gone through most of my life kind of flirting between feeling quite good and a bit less than good, just being fine a lot of my life. And that, on the whole, that's what I meant. I've not suffered. I've just been kind of moving along on this range between a 4 and a 6 out of 10 all the time. And it's like, actually, I'd love to explore what 8s, 9s and 10s feel like. I'm sure with that there'll also be some real lows as well. Learning to feel the lows.
There will. I fell foul of that myself, and of the sort of unhealthy positivity, and it's a fine line, that crikey, we could get into some of the research of like Masaru Emoto's work of messages of water and focused mindful activity of what that does to crystallizing water and the vibration patterns of water and all of that kind of stuff, and the power of the mind. And it is hugely powerful. Self-talk, all of that, it is important. But then there's this, I went down a lot of that in a sort of a Zen journey for about 20 years. And martial arts and what have you, and it was hugely powerful. And we went, so I've also learned that we must be in contact with all different. A capacity, back to that river idea, where we sort of expand that capacity, is our ability to be with an experience. A lot of this comes down, can you be with that? Okay, well, there's that thing. And we go, oh, it's an overwhelm. There's the thing. I was working with somebody yesterday, found it terribly, terribly difficult to actually physically cry, and there's all sorts of ways in which that becomes, just avoided. Either cognitive becomes, oh, I know what this is. Can we sit? Yeah, I'm interested in that. But could we come to that in a moment? And they're like, oh, no, you're making me sit with this difficult experience. Yes, I am. Not in that way, I wouldn't, of course. But yes, can we build a capacity to be with all experience? And actually, just as the Buddhists say, everything in life is transient. Our life, our breath, this moment, this emotion. There is not a single experience that you are still experiencing that you have retained throughout your entire life. If we allow that emotion to flow through, it will be transient. But we usually go, my past experience is that experience, if I think about that, if I see that image, if I feel that feeling, if I have part of this experience which is overwhelming, I must avoid, which leads to defenses and resistances. And they might be physical resistances in terms of muscular bracing, they might be habitual and relational defenses, etc. So, whenever we meet someone's defense, that's where we're onto something, and that's where we need to work. But at the end of the day, I deal with probably 50% of my work is in the realm of sexual harm, the repair of sexual harm, and I'm doing a dissertation on the importance of touch in the repair of sexual harm at the moment. Talking about those very early infantile responses of we're held in a womb, and can we trust that? I mean, can we even get into the sense, and I've got people where we're going, I'm looking at one facet of my dissertation is around actually children who are born of rape, and the unconscious fetus being aware of the conflict of the fact that mother is likely to love it naturally as a baby and an infant, but also to be terribly conflicted with the energy of the fact that child has come from rape. And that affects the energy field and the experience, potentially, and the biochemistry of that infant. And you go, well, when if you've grown up and your experiences, and I'm being cautious here because I don't want any kind of identification of any individual that I've worked with for obvious reasons. But I can generalize and say that some of the things that people, they've got sibling rape, they've got incest, they're beaten up. I've had people who get cigarettes put out on them, etc. So their childhood experiences are horrific, absolutely horrific. And have been through incredible traumas. And you go, you can't just be positive about that. There's a grieving that needs to take place. And very often we meet people, and when we get past these defenses, there's a sort of a grief of the loss of something or other. Or we lose a parent when we're young as part of those age, and then we go, well, can we grieve the loss of it? Because if no one was there to support you, an ungrieved process might be something that's going on. You can't just positive your way out of it. And actually, it angers me That angers me, actually. I get anyone that ever dares to sort of suggest that anybody that's coming into my work to do, deep therapy work, if they were to dare to actually criticize them and say, oh, well, it's all whatever it is, mental health, I would go, you give me an hour with you, 2 hours with you, and trust me, I'll find out a whole pile of stuff, because we've all got it. Now, the most courageous people are the people that have the courage to come and sit in front of me and in my office and do this work. And I know that because I've been there. Yeah, and I've sat in that chair, and actually that's very reassuring to a lot of my patients to know that I've done the hard yards. I've cried, I've wept, I've shook, I've hyperventilated, gone back into trauma experiences of anesthetics. I've been there. And it's the most courageous thing. And anybody that thinks that people that go through therapy are, weak or mixed, no. Come and sit with me. And, that I'll prove you wrong, because it's everyone's got that can benefit from therapy. But that anger that needs to be allowed. So we can't positive these things away. You can't be positive about the fact that you've been in a war zone. It doesn't change the fact that you collapse on the floor, wet yourself, and have flashbacks when you hear a car backfire. You can't just positive your way out of it. We must meet, but can we be with all of the experiences and help people to actually process and be with a difficult experience to allow them to move through? That, I think, is a lot of our work.
That links to this fallacy that is in slight contradiction to what we were saying earlier about hope, in that some people will have symptoms for a very long time and some forever, and often people come to us expecting to be healed, fixed, pain-free, symptom-free, and achieve a moment of, or at least a status of completely fine. And that isn't the case for some people, many people, although there are also many people that do achieve excellent outcomes and have full recovery. There's many that don't.
Uh-huh.
I find it hard. I find that hard to communicate at the right time, and for a person in front of me who is clearly got a complex presentation where I don't know whether they will be better. And I lean on the side of honesty these days,
uh-huh.
and explain that in a way that I hope doesn't take away from hope, but it still has that connotation that hey, look, you might not get better. How have you found juggling that with your clients? Because your client list is on another level to mine in complexity and in that deep-rooted trauma, I would imagine. How do you navigate that complicated situation?
So I think there's two facets to that. One of which is, I think that a lot of people in the pain space these days are talking about helping people live with pain. And that's important for us to be able to do that. But I think that too often people are working on the premise that that's what we need to do with pain. We can't make promises. We never could. We can never say that we can, help anybody, even back in those mechanistic days of going, yes, that's fine, I'll get you writer's rain in 6 weeks. Be careful making that promise. Yeah. So we can't do that. And we shouldn't. But I'm transitioning my own YouTube channel from the Rodger Duckworth one more into, as I'm separating the my physio team slightly out from my own work into, and the other one is my own sort of Rodger Duckworth channel, and it's called Hope for Your Healing. And so I do think that actually very often I go, no, I often say I help people, you see my videos, and I say I've been helping people not only manage but recover from their chronic complex and health issues. because I've seen so many people that have been trying to learn to live with their chronic pain, and I go, well, no, we've actually resolved it. So we've got to be careful that we don't just kind of go, sorry, can't help you, because actually there's tons of people who've got chronic complicated health issues and the NHS just goes, sorry, don't know what to do with it. You're going to have to learn to live with it. But most of my caseload is helping those people, and they actually go, oh, how they get better. So I think we just have to sort of navigate this space of going, there is potential, but I can't promise you. Now, there is hope for your healing. And what my experience is, I've got a busy list. I don't need to be treating you and working with you. And what I will not do is work with somebody that I ethically don't feel that I'm helping. We can't do that ethically as practitioners, and I won't. So if I can't help them, I won't. But that's rare, because we go on a journey of going, well, yes, and it might be that I don't help that pain in quite the way that you think, or actually very often the pain goes after. But it might be that we go, well, you've helped me so much because actually I don't get that. I'm out of depression now. I don't have that. There's some people I'm working with right now that I'm going, well, actually, they've come off sort of oxycodone addiction and things like that. And they go, well, actually, basically I'm off all that lot. They've gone from being slumped in the corner of my room rocking when they arrived to now being interested people that are going out and rebuilding their lives and getting back into work and doing all sorts of things. And they're going, yeah, my pain's come down, but it hasn't all gone yet. And I'm going, I know, because actually we need to, apart from deal with the titration, we've got to actually help people to break the patterns that might be bracing, or actually that pain might only come down when we get the sensitization in the nervous system down. So it's like, I'm not focusing on your pain anymore, but I'm aware that that's there, because is it that actually we're dealing with chronic armoring and bracing patterns? Okay, well, that might shift faster. If we're dealing with somebody who's got a very traumatized nervous system, we could look at it through the lens of central sensitization, of going, well, if they are on red alert the whole time, the only way that pain's going to come down is by, that's another wise, ordinary sensation that's now being processed as a pain signal. We know all this stuff. Well, then we just got to work on, okay, well, let's work on your relationship. Let's work on this angle. Let's work on the depression. Let's work on what's going on in your experience in your body. And if we can work on that, then there's hope. But I don't know where we're going yet. And, we allude to the therapeutic process in a more psychotherapeutic process, or, if it's got a more somatic psychotherapy, which would be, sort of that top down and bottom up, which is very much my approach. Yeah, people go through therapy and go, well, what was you hoping to get out of it? And very often they'll get far more out of it than they actually went for. They might think they're going because they're going, oh, well, I've got some, anger management issues. And all of a sudden you're kind of going, well, actually, oh, blimey. There's,
it's the onion layers, isn't it?
There was so much more about it. Yeah. So people go into psychotherapy, will often just kind of go, well, all right, well, let's just meet you where you are, and let's just go on a journey. And it's less about, well, I've got a pain here, so give me a pill and get that thing to go away. So, yeah, I don't know whether I've answered the question really, but there's a sense that I think we can have hope. And most people that I work with find that they, as you say, to the onion layers, they explore far more and find so much more. It's that richness again, that once they start exploring and go, I was speaking at a conference in York last year on EMDR and whatever, and I think Richmond Stace was there talking about pain as well. He was another speaker. And he was doing his thing, and he was just passing the mic around because he's quite interactive when he does his stuff. And he was passing the mic around, going, oh, "Tell me what you think pain is, or whatever." And I kind of went on the speaker's table, and I kind of went, "Can I say something, Rich?" And he went, "Yeah, sure." And I took the mic. I said, "I've just thought of this acronym: pay attention. I need pain. because that's what pain is. It's communication. Yeah. It
It's
doesn't.
a need state.
It's a need state. Yeah. And it might be, I need you to pay attention to this. I need you to stop hitting my hand with a hammer. Yes, of course. Or I need you to take care of it. See, it might be structural, but it might be, I need you to pay attention to something. I need you to stop behaving that way. I need you to stop working that many hours. I need you to stop processing anger in that way, or deal with this deep sadness and stop avoiding it. I need you to. And
it's our job to help that person understand what follows the N, what follows the need. And sometimes it's simple, sometimes it's complicated. And that's what today has been about, the complicated, not the simple. I often say similar things to you, by the way. I was kind of nodding along as you were describing how you navigate that paradox of, sometimes people don't always get better, but in my experience, people do amazingly well despite pain. And in the end, that pain sometimes will shift and move and become less of a problem. And even if pain continues, there's a really good chance that you'll be happier, healthier, fitter, stronger. And wouldn't that be a better life for you? And then by not focusing on pain, on that need state, sometimes it drifts away because you're not paying attention to it anymore. Perhaps you're so habitually paying attention to pain that's feeding the beast. That tame the beast from the Noy group. It's comes back to that.
I mean, I live with tinnitus. I was knocked over. Another thing, I was knocked over as a kid when I was 10 years old. And, possibly it was around about the same time my mother was very ill. So possibly I've done quite a lot of work and it doesn't shift. On that, that's one thing that does not move. Everything else is pretty much calm. And I had a head injury and smacked my head through a car windscreen and it started then. So, and I haven't been able to shift that. Now, I live with that. And actually, most of the time, I ignore it. Mercifully, it's not like a jumbo jet taking off, but it's a persistent hissing. I can hear it right now. Now I'm paying attention to it because I am paying attention to it. But most of this podcast, I have not been aware of it. I think we have this thing that we assume that we must be perfect. Well, whatever perfect is just fine the way you are, and if we get deep enough with it. But people live with all sorts of challenges. People live with all manner of afflictions. People live with amputations. People live with MS. It's not going away. And so is pain, chronic pain, can we view that through the lens of these other conditions that people, Parkinson's, that may be managed or have to live with, and is pain different? But we've lived in this world that assumes that pain must go away. So I tend to focus on, my focus is, and my experience is, to for the hope for the listener, in a way, if they are suffering and not just a clinician, that actually pain, most of my patients recover from their pain in time. So it's not just for me. Yes, there are some people that we go, well, okay, well, we didn't manage to clear your pain, but what else did we do for you? Or, well, it's significantly less. But yeah, maybe we do. There's the other thing I'm thinking now is grief here. That, and I can actually remember, I was very lucky actually in that my original training years ago was one of the, I think it was about 2 schools in the country at the time that were also integrating mental health. So I've got sort of mental health training from outpatient and inpatient work, and was very lucky to work in that field back then. And I even remember as an undergraduate writing a psychology paper on the importance of understanding grief as a physiotherapist. And you think, oh, that's interesting. Well, why is that relevant? Well, yeah, because we deal with people with loss of function all the time, loss of a limb, loss of agency, grieving the loss of the pain-free life that you had. Sometimes, when we have things happen to us, whatever it is, if we go through tragic loss or a divorce or a loss of a loved one. We must grieve. And actually through the grieving process, in my experience, sometimes I've also had to, sometimes the pain goes when we grieve it. It's a bizarre thing that sometimes we meet things. Either we grieve something else and then that was part of the pay attention I need. But sometimes I've even had patients and clients where but actually the process of being in contact with the grief, the pain itself, and really somatically we might be with that and then work with it and see what comes out. And very often when you pay attention to the pain and you actually work with it as a sensation, sorry, I'm closing my eyes because I'm going into that own somatic experience of it, that then very often we will talk about titrating. So we will kind of Coke bottle out what was buried and locked. And sometimes there's deep sadness within there. Sometimes you'll find emotions. Sometimes you'll feel just energies that don't even identify as anything, but you'll feel them move through. And then sometimes you'll just go, I've got these tears and I go, I don't know what I'm crying about. And I go, it's okay.
So sometimes that pain
Go.
may be
and the pain then goes.
Better than the other pain that it's actually blocking up, bottling away.
Yeah. That's a really important point, actually, because very often here's a fascinating example that I think I can say without it being, too identifiable. But I'll sort of try and edit as I go to make it sort of not a breach of confidentiality. And it's not the only example I've seen, but. I had somebody when you can't say no and the body says no. It was literally an example of this where someone was getting multiple joint pains, and they tried loads of physios for this, that, and the other, short-term placating treatments and so on, and they just kept getting and adding more, both shoulders, back pain, both knees. And it was so fascinating that when we went through their history, and actually when we worked with these, and it might just be that we were just unpacking this shoulder by moving it, it wasn't even a conscious process. Through this came this rich story and narrative and emotions flowing through of someone who's had a fractured home, mother abandoned, and the mother was unable to your own story really of really unable to deal with her own emotions compassionately. So it's not blaming the mother, but it's just saying, well, look, this is ancestral. This is the way it happens. And so she couldn't deal with her own emotions, and so she didn't really know how to deal with her son. She didn't really know how to interact at that emotional level. And so every time anybody felt a bit weird or whatever, it was like, oh, well, let's go out and kick a ball about, and let's go out and do this. And it was always, let's go paddleboarding. And they were very sporty, and it was always active. But actually what was happening was it was going, the body, and this chap was a huge rugby player, about 6 foot odd. And we did this thing where we said, right, okay, what do you need to say to your mother? And we sort of stood him up and did the empty chair technique and sort of said, well, if you're sitting over there, what do you want to say? And he said, well, I want to say, I don't want to do that. Or, no, I don't want to go and do that thing. I don't want to go paddleboarding. I want you to give me, I want to cuddle. And, I went, okay, all right, so try to do it. And he just went, ah. And he couldn't do it. So we did a whole bunch of things and various techniques, and stuck her in a box and shrunk her and stuck gaffer tape over her mouth and all sorts of imagery. And I stood next to him and kind of put my shoulder next to his shoulder and we worked with building this agency energy in his spine and then uncoupling this kind of freeze response in his body. And then he was able to say this thing. And then he just, shoulders dropped and he just went, oh, pain's gone. And I'm going, see, that was your body going, oh, well, I can't say no verbally. So what I'll do is I'll just give you so much pain that I can't go cycling because my knees hurt. I can't play tennis because my shoulders hurt, because that's my excuse. So that my body is communicating a no, yeah, where you can't, where I can't use my words. There are so many thousands of examples I could give you of how this plays out, and it is fascinating.
So the question becomes, what is the pain teaching us?
Yeah.
What do we need to learn from it? So there are times when a distraction technique might be useful for coping. There are times when it might help to create some relief. But what we're really discussing here is what is the pain teaching us? What are we going to learn from this in order to fully heal? That sounds like the main punchline.
And be curious. Can we just be curious about this and go on a journey of exploration? But we can't just dive into these things. That's another whole kind of, there are ways in which we just have to sort of just like, I might use analogies where we're just on the edge of something. I might just say, what if we, if that pain was a lake, we don't want to dive. It's so tempting to dive in the middle of it. But what if we, if you start to walk towards the lake, and I even use visuals, what if you start to walk towards the lake? Notice what happens as you start to walk towards it. Could we just sit on a park bench by the side and watch the ducks?
I often say, should we just dip our toe in the water here?
Yeah, exactly. And I'll do the same. And that's a titration process of kind of going, can I just be with it? Or can I touch it and then go, right now I need to go back out and I need to resource something and I need to go more parasympathetic. I'm going into the trauma. We have to go into the trauma vortex in order to heal it. But, you can't throw yourself into it because then you're just re-traumatizing it, which is why sometimes talk therapy alone creates re-traumatization. People will often take themselves back. I was thinking something else that Freud talked about, repetition compulsion. And so there is this notion of this, for anyone that's sort of working with this idea of a trauma vortex outside of the capacity, it's like if you're paddling along the river and there's a breach in the riverbank, you would feel the pull. Well, that's what you're feeling and that's what you're tracking for when you're going, oh, they're going. And we work there and then we just go, okay, but whoa. We have to, another analogy, we have to go into the turbulence and we have to fly the kite in the wind, calming, regulating, meditating the heck out of everything. I know because I tried it and it only takes us so far. It only takes us halfway because we have to then learn the skills of that now, kind of the rope on the kite to then go, now we've got the skills to have a bit of parasympathetic. Can we go into these trauma vortexes and can we find ways delicately? And this is where the other piece is that trauma happens usually in isolation and healing happens in relation.
A smooth sea never made a skilled sailor. I think that was
that's the other one.
And that's what you're helping people with. But you also wouldn't chuck an amateur onto a boat in a storm.
Into a force 10.
Yeah.
No.
So I think that's the art again, the artist that comes through. Yeah. Before something very important that almost begins the process is highlighted by a joke you told me right at the beginning about psychiatrists.
Oh gosh.
So what someone coming into this journey has to be ready, right? So tell us your joke. So start wrapping up
so the tongue-in-cheek joke was how many psychotherapists does it take to change a light bulb? Only one, but the light bulb has to really want to change.
Yeah.
And so we have to be willing. We have to tap on the door. I can't go out there. And, I have a brother and I've had to do a great deal of grieving. I have a brother who's an addict. And I had to grieve the loss of the brother. But and it's difficult. I can't help him because he's my brother and it would never work, to work with my brother. But actually he doesn't want. And that's a terrible pain to observe people that are struggling, which is why I do my channel, why you do yours, of going, I want to reach, it was why I hope for healing, because there's so many people I'm going, if they feel safe enough, if they feel able and willing and courageous enough, and I don't mean that disparagingly at all, like, you've got to find the courage. No. I mean, it is hugely courageous. So when they find that this ability and a safety enough to come to meet someone and tap on the door, then there's hope for some form of healing, whatever healing is, and improvement. And I feel very passionately, that's why I'm a healthcare practitioner, of kind of going, well, look, we don't know till we try. And I can almost always say that there's something that we can do. If you want to tap on my door, I'll bend over backwards and do whatever I can to help you.
If the listeners would like to tap on your door and learn a bit more from you, how might they at least digitally tap on your door?
Yeah. So if you put Rodger Duckworth, and it's Rodger with a D, so it's Rodger, Rodger Duckworth, Rodger Duckworth Physiotherapy. I've also starting to put separate ones. So if you put Rodger Duckworth, you might find Grange Health in there as well. And I've got my YouTube channel. There are 2 channels again on that one, but type Rodger Duckworth into YouTube and you'll find lots of content on that. And I'm out there on Instagram and, LinkedIn by my name, really, Rodger Duckworth.
Where is your physical clinic?
Physical clinic is my practice in Wokingham, which is in Berkshire, just south of Reading. But I do work online. I have international patients and clients. I do have people frequently travelling an hour more to do in person. And personally, I don't care what anybody says. Nothing beats in person, because I do use a lot of touch as well, and unconscious touch and things like neuroaffective touch to really tap into those primitive, powerful aspects to touch and not normal manual therapy. So, yeah, working in Berkshire, online or in person.
And we always finish our episodes by asking the guest, what does better never ends mean to you? And the reason for this, it's my personal tagline for my life. My infinite purpose is wrapped around the concept of better never ends. It inspires me and pushes me on every day. What does that mean to you?
Better never ends. My practice manager, my office manager, she says, you'll never retire, And I probably will come a point where I don't want to run a practice and employ people and that, but I don't know that I'm ever going to stop, really. Because, I feel like I kind of won the lottery, really, because this is my hobby and I get paid for it. I am one of the fortunate people that kind of goes, I still love working with people. It fuels me. It humbles me. I could just keep learning forever. And as we said before we came on, the more and more you realize I don't know anything really. And I'm great with that. What I've learned along the way is that there are clinicians out there, and they tend to fall in 2 camps. There are the ones that can be surgeons, it can be anybody, and there are people that go, well, if the patient doesn't get better or I don't know what's going on, then I just go, oh, well, never mind, you can't win them all. And I go, no, I'm excited by stuff I don't know. That for me is the better never ends. That's the sense of kind of going, I don't know that yet. Great, brilliant. And I really been going to the Oxford Trauma Summit for a number of years, and I think it was about 2 years ago. I was sitting in the audience, and Bessem van der Kolk was there, and he said 2 things actually. He said one, somebody said, "Oh, what's better? Is it EMDR or this or that or the other for such and such?" He said, "You know what? Here's what I've learned. Whatever you do, make sure you go and see somebody who's got at least 3 disciplines under their belt, because if there was one that was perfect, we'd all be doing it. So if you have to, I feel passionately that somehow, and in fact I'm sort of wondering, how on earth might I teach this, or how can I offer this, and how can I share? And if anybody's got any suggestions, please reach out and let me know. Or if you're interested and you go, I would love that, then never know, I've got an audience and I'll deliver it. But I think we have to find a way in which we can bridge psychotherapy and physical therapy. We have to, or else we're just perpetuating the Cartesian split. And for me, a real learning edge for me is around how we actually teach. So I've got my own learning edges in terms of what I don't know, but of course I think as a professional edge, there's a sense of how do we get physiotherapy, we can't have them all trained to psychotherapy level unless they choose to train as a psychotherapist. But how can we bridge that gap? And I don't know that you necessarily need to have all of those skills in order to be able to effectively work with people. But somehow we have to find a way in which we help people to bridge that gap. Aileen Lapierre, that I work with, she talks about the taboo of touch in psychotherapy, and I don't know what you're on about. And the psychotherapists have this real big bridge of kind of going, we don't touch, and actually we don't really know much about the body, really that much. And I'm like, surely now is the time. Now feels like the time where somehow we have to bring that back together. And that's what gets me up in the morning.
Bridging the gap, mind and body.
Yeah.
That's the one. Thanks so much. Really great. Thanks, Rodger.
Thanks for inviting me in, Charlie. Thank you.
Thanks for listening to today's episode. If you've made it this far, that probably means you've enjoyed the show. Please leave us a review and subscribe to the show on whichever platform you use. I've been told that this stuff really does help us to reach more people like you. And if you are someone in charge of things at work, book a demo call with Jane to see it for yourself. Use code Physio Coach 2MO to get 2 months free. To stay up to date, follow us on Instagram at Better Never Ends or on YouTube, the Physio Coach Podcast. This podcast is a product of Better Physio Group, provider of physio and PT services in central London, helping people in pain, suffering with injury to feel better and live better. There's physio, and then there's better physio.